As you have heard from the previous presentation, hip arthroscopy has gained a lot of popularity in the last 2 decades. And we are talking much more about hip arthroscopy in elective patient, while we are talking less in trauma patient. And I will show you some cases of trauma patient. At the beginning of hip arthroscopy, we were doing hip arthroscopy for trauma only to remove bullets, to remove intra-articular fragment after a fracture, or to remove a labrum which was interposed between the head and the acetabulum after a dislocation. And I will show you some example. This is a bullet here. You can see it here, and you can see it's a hunting bullet that bounced from the floor to the hip of this poor guy. And this is the CT scan where you can see the bullet, and you can remove it arthroscopically. It's not so easy to find it, but you can use the C-arm and you can localize it, then you can remove it with a little capsulotomy. Or you can remove some fragment like this one. This is a 14 years old, sorry. How can I play it? Yes. This is a 14 years old guy with a posterior fragment of the posterior wall inside the joint. You can see it there. And I could remove it arthroscopically. You can see the fragment here. And I can remove it and do a labral suture after having done this. Then you have labral interposition. You can see the labrum here inside the joint, okay, with a little fragment again of the posterior wall. Again, it's a young patient, and you can remove this. You see the labrum is completely introverted inside the joint. You can postpone the labrum and find the fragment and remove it. This is what we were doing some years ago. Now the new era came, and we are doing reduction and fixation through arthroscopy. This is the difference from what we were doing before this. The first indication that came to our mind is femoral head fracture. If you deal with femoral head fracture, you probably think about arthroscopy not in the type 4 Pipkin fracture. You may think about it in the type 3. You may fix the type 1 or type 2 and with arthroscopy, and you can fix percutaneously the neck fracture. But the first indication that came to our mind is the Pipkin 1 or Pipkin 2 fragment. Cases like this one, this is a posterior dislocation with a big fragment of the anterior part of the head. It's very complex, and it's not easy to choose what to do. You can reduce it. Obviously, you have to reduce it, otherwise it will fail. You can do anything, just leave him on crutches, but you will end up with an arthritis of the hip. You can do an arthroscopic removal of the fragment, but the fragment I show you is really big, so you remove half or 1/3 of the head. That is not so good for congruency. You can do an open reduction and fixation, or you can do an arthroplasty if he is an old guy. Probably, if it is a young guy, most of you will choose to fix the fragment, to fix that big fragment, to not avoid any loosening fragment inside the joint, and you want to have it well fixed and well reduced inside the head. But doing this is not so easy. If you use a posterolateral or lateral approach, you can't achieve what you want to achieve. You can use an anterior approach, but the screw direction will not be perfect. So you have some problem with every approach. You can use a medial approach where you have a wonderful view of the fragment, but you can't really understand if it is completely reduced, and you have an excellent screw direction. Or you can use a surgical dislocation described by Gantz. You have a 360 view of the femoral head, so you can fix your fragment wherever you like. You can fire your screws with the direction you choose, but it's a major surgery. You do an anterior dislocation in a guy who had a posterior dislocation, so the capsule will be completely destroyed. And this is one case, just to show you. It's a posterior dislocation with multifragmentary fracture of the femoral head, and you can see the head here with a heel sacs lesion of the head. And with this case, in those cases, we don't use hip arthroscopy, but we use surgical dislocation, and we fix the fragment. And I think this is a good result if you consider the starting point. Then you can fix the labrum, you fix the trochanter, and this is the result at 5 years for a complex case. But if you have easier case like this one, where you have a single piece down here, a real peak in one fracture, one fragment here, you can consider an arthroscopy because it is less invasive. You have a wonderful fragment view, you have a wonderful reduction view, you can fire your screws with a proper direction. It is less invasive, it has no invasivity comparing to the other approaches. You have no risk of necrosis, but it has a learning curve which is to be taken into account when you start with this. I show you some case. This is a Pipkin one. You can see the fragment down here, there. I do that supine with no traction, with a figure 4 position. You will see later on why. I use the balloon technique, popularized by Dinst. I hope he's listening to me. I use the superior portal, which is number 5, and the anterolateral portal, which is number 1. With those portals, you can get easily to the fragment. You can see the fragment down here. At the beginning, you can't see anything. There is a big hematoma. There is a lot of fibrous tissue. Much more time has passed from trauma. So if you do it on urgency, it's better. Then you start seeing something. You start seeing your fragment. You start moving your fragment, as you can see here. Okay. For those who are not familiar with this, the femoral head is down right on the screen, the capsule is upside, and the fragment is the one I'm touching. Then you can reduce the fragment with a spiky instrument. You can see the reduction here. It's not easy to find. You can put it up, but it's not easy to find the perfect rotation, so you need sometimes to find this good reduction. I think it's a good reduction. I'll leave you the decision. You can check it with the X-rays, and you see the good reduction. Then, once you have achieved the reduction, you can do a third portal, which is the medial portal. The medial portal comes from the Ludolf approach, from the medial approach, and that's why I met Professor Hamed, and that's why I'm here. We talk about this a lot, about the possibility to have this medial portal. With this medial portal, you can fire one wire and fix your fragment like this with the proper direction. It's almost perpendicular to our fracture. And then on that wire, you can put a screw. You will see the screw coming. Here, it's not easy because you have a lot of tissue from the skin to the femoral head. So you struggle sometimes to push down the screw. Then you can repeat the operation, and you can do a second screw just to fix also the rotation of the fragment. And at the end, you can check your rotation. You can check your reduction. You can see the reduction here, and you will see the screw head somewhere up here. Obviously, the images are not so well. You can see there. There is the whole of the fragment. This is the reduction up here, and you will see the femoral head in a while. It's up here. There. Okay. As you probably can imagine, it's not so easy to have wonderful videos because it's a fracture, so everything is bleeding. You have a lot of blood inside the joint, so it's much less good for meeting than the elective surgery. But this is the result, and I think if my hip was this one, I would be very happy that someone did it arthroscopically. Is it easy? No, it's not easy. It's difficult to choose the correct wires. If you use little wires, they are too flexible, and you risk to breaking them, pushing down the screw. But you need long wires because the skin is, as I said, is far away from the head. If you use little screws, it is what we would like to use, you have usually short screwdrivers, so you can't really reach the skin. Sometimes I have to open my portal to reach with the handle of the screwdriver, the place where I want to be. And the other thing is they are not retaining, so you lose the risk of losing your screw while you're screwing it. And that's why I use always a little wire as a cap inside the head. You have seen it in the video. We are working on that. These are all technical problems. We are working on a dedicated instrumentation, so we will have long screwdriver and everything that meets our expectation. If you do that properly, you can achieve this result. This girl is a 17-year-old girl. I think she never did so much jumping in her life. She was very big. I struggled a lot, but now she can do that. So I was very happy with this. Then the other indication is the other side of the moon, is the acetabular fracture. On the acetabular fracture, can we do something arthroscopically? Yes, I think so. We can't do that on both column fracture, but we can do on posterior wall fracture. Some posterior wall fracture, I'm not saying that all posterior wall fracture are going to be treated arthroscopically, but some of them, the partial posterior wall fracture, could be treated. If we look at AO, the AO says that if the posterior wall is less than 20%, you can leave there alone, but you have the risk of late instability. And I agree that there is a risk of late instability, and I agree also that if I have to do it by open surgery, I would not open a hip to fix a little fragment like that. But if I do it arthroscopically, I can see them on the monitor on my screen. If I do it arthroscopically, I would fix it. As you can see from this case, you will see posterior wall here, stopped somewhere. Okay, you will see it here. No, you can see it. Sorry about that. You see the fragment here? Yes, you can see the fragment down there on the other screw. Okay. So very little fragment. I do it arthroscopically, and I do it on the lateral position because it's easier to get behind the hip. I use the anterolateral portal to see the posterolateral portal to work, and I create another distal posterolateral portal to fire my screws. This is what you see in traction, so you fragment up here. Okay, sometimes you have to release a bit the traction, otherwise it pulls too much on the fragment. Now you can see the femoral head is on your right, the acetabulum is down here. You can see the fragment. I'm pushing it with my radiofrequency instrument. Once you remove all the tissue, you can remove it and you can reduce it with again with a spike instrument. You can see the fraction down there, and you can see the reduction. Up here, you can check it with your C-arm, as you can see here. I think it's a good reduction. Therefore, I will fix it with some screw. You can see the screw there. You can check it with again with a wire and a cannulated screw. Here, you can fire a second screw, and you can achieve this result. I think it's a good result. If you see the obturator view, it doesn't look perfect, but I saw the cartilage, and it was perfect, and you saw it. So that raised the question if sometimes by open surgery, we close everything. It looks very well on the X-rays, but not on the inner surface. Again, is it easy? No. We have no retaining screwdriver. This is a big problem. I lost one screw inside the joint. You can see it there, inside the joint. It takes 20 minutes to get it out from the joint. It's not easy, it's not funny when you do it. So we need, again, new instrumentation. But it's very interesting because we have to learn how to put our screw. The screw direction is not the same as we are doing normally. We avoid to penetrate inside the joint because we can see it, but we don't know if we get out from the outer surface of the acetabulum, so it's not easy. And since you are in lateral decubitus, you can't do the obturator and the alar iliac view, so sometimes you're not perfect. You can't understand if you are perfect with your direction. The other thing is you can break the fragment while you're screwing it. Sometimes it happens, and this is a pity, but it happens. And the other thing is timing. It's a lot. We know that we can put a guy on traction for 2 hours, no more, because otherwise he will have a nerve palsy. So it's a steep learning curve. Yes, it is a steep learning curve. You have to have knowledge, traumatological knowledge, pelvic trauma knowledge, and hip arthroscopy knowledge. I would not suggest you to start with hip arthroscopy in trauma, but I think it's interesting, and it's long, it's time consuming. It's the same objection they did on ACL, the first ACL arthroscopic fixation. I think we will fix Pipkin fracture arthroscopically in next years. We will lose all the approach, but we need a lot of time to improve our results. If what I said it was interesting for you, I would suggest you to get some more tips in my articles that I published recently, and you can find all the technical part of my presentation. Thanks.